Morning, everyone. Finally, I was having a little bit of trouble showing up on this screen. It's noon right now. I'm just going to see if a few more participants join because I'm the only host, so I'll have to let you into the from the waiting room. And as we wait for a few more people, I want to just thank you for your interest in this workshop. Thank you for taking time off your busy day to discuss this topic today. I'm really thrilled that you're here. I'm actually going to have an offer at the end of the workshop, so I hope you stay with me through the end. This is a 1-hour workshop. I'm going to go ahead and put my screen up so that there's a short presentation, and then we are going to have some discussion time at the end. So I'm going to go quite fast through the presentation because it's just really to throw out all these ideas about this topic and then hopefully give us a little time at the end, maybe 15 minutes, hopefully, to go ahead and do that. So people are still joining, which is a good sign. And the time is always an issue because I'm trying to get people from the West Coast, people from the East Coast, and sometimes people join from Europe as well. So it's a tricky thing. And I know it's daytime for those of us in the East Coast. So let's see. We'll get started in about 3 minutes. And feel free to keep your cameras on so we can all see each other if you can, but no pressure. I'm actually recording this presentation and I will have it on YouTube later so that hopefully you can share if you enjoyed it and review it. And yeah, please use the chat room. And oh, someone's joining us from Istanbul. That's fantastic. Welcome. Actually, why don't you post where you're connecting from? That's a great, Duiju, is that how I would pronounce your name? Duiju?
It's Duygu.
Duygu. Okay, thank you, Duygu, for participating with us. There we go.
Thank you for sharing.
Maryland, Indiana, fantastic. Yes, Robert Lee, it's great to have you from Boston. Yes, Angie Ramos, CHI from Wanakee, Wisconsin. Jeanette Justin, great. I see some colleagues, it's wonderful. The new people as well, welcome. A few more coming in. Time zones are different, so we have to give everyone the benefit of the doubt. I don't want to get started without at least having most people in. Fantastic. Where else? Where else? Not everybody said where they were coming from. Concord, California, fantastic. All right, good. We need the diversity. Now, are most of you medical interpreters or healthcare interpreters? Do you dabble in both? Fantastic. This presentation will really be primarily focused on the medical interpreting context. I am sure some of you will be able to correlate with some other fields, certainly, but just, pardon the, our focus is really on that specialization. Alessia from Italy, yes, great to have you. Fantastic. Well, what I will attempt to do is present and be aware of anyone else joining in. I want to make sure that I don't miss anybody in that waiting room. So let me share my screen with you all so that I can pull up the presentation. Hopefully you can see, can you all see my screen? Oh, let's see, I'm gonna have to Can somebody answer? I just want to make sure the screen
Yep.
sharing is
Yeah, I
working.
can see your screen, Isabel.
Perfect. Okay. So let me go ahead and start the presentation. Oh, 2 new people. Let's see. Good. I'm keeping the chat open and moving everything. Okay, so let me see if sometimes let me share. So the presentation today is about intercultural mediation, a game changer for medical interpreters. And you'll understand a little bit more why I'm talking about it as a game changer and not just a role or an activity. So let's get moving. Just for those that don't know me, I'm an interpreter, instructor, advocate, author, researcher, and lobbyist. And primarily, I like to see myself as a change agent. And I'm just showing you a little picture there, which is the inauguration of the National Board of Certification for Medical Interpreters. And this was a special date for us after years of work. On October 9th, 2009, we inaugurated the first national certification for medical interpreters. And, you know, it's hard to believe, but, you know, here we are over 10 years later, and it's time again for us to shake the tree and keep evolving this profession. We now have 2 national certifications in the US for medical and healthcare interpreters, which is wonderful. The RID and sign language interpreters are really working towards a specialized certification. And I've worked in, this is mostly my advocacy work, but I've also taught interpreting at Osaka University, Cambridge College, Boston University, Bridging the Gap, and you name it. I've participated in a lot of teaching. But my latest work has been related to intercultural mediation. So why am I putting this picture right at the start? Because I want to give you context. We know that a trend that will never change is this trend of migration, increasing ever more. And we've seen it in the last 100 years and in the last 10, just how much, even a pandemic can't stop travel, right? And what we're seeing is that migration of individuals will continue, and with it, we will continue to see the interlinguistic needs growing and also the intercultural needs growing. There's no doubt about it that individuals, when placed in a new environment, they definitely, you know, not only require language services if they don't speak the local language of their new home, but they also have the whole acculturation at their hand, and you know, they need help with that. And what we're seeing is that a lot of the problems in the world have to do with issues of acculturation on both sides. Intercultural interaction is becoming more and more difficult because people are just not used to so much diversity. Here's a little bit more on context. Especially in the healthcare field, we've seen several standards come out in the last decade related to providing culturally and linguistically appropriate care. Now, mind you, none of these talk about just linguistic access. They also talk about cultural access. And cultural competency isn't just about providing a special service. I think in the beginning we saw it as an awareness, as a sensitivity. It's had many names, right? Competency has stuck around, and now we talk about cultural humility. But the fact is that it has to do with cultural interaction and the complexity that brings. And it's really, in healthcare, it's not just about providing special services. It's about ensuring that remedial actions or closing gaps are taken care of so that we can provide health equity or healthcare equity to all. And mostly so we can provide patient safety to all. And we're seeing a huge increase in the need for health equity and equity in all areas. So that's just the context. I wanted to put 2 slides here just to give us the context. Why are we talking about intercultural mediation? Because it's important, especially in healthcare. So the goals for this session are really to talk about, define intercultural mediation, talk a little bit about the controversy within intercultural mediation in our field, evidence-based practice, and I want to throw out a strategy for advancing the profession, and I want to hear your opinions, your honest opinions about this. And I really think at this juncture, it's a time for us to reflect on our actions and decide what needs to change, especially in our practice. And I think, if I may use the COVID-19 framework, definitely the last year, everybody's slowed down. People are really thinking about their work. They're thinking about their values. And so I think it's just a great time for us to, rethink our profession and where we want to go in light of all the trends that are going on. So let's start with the definition, right? Here's one definition I can propose to you. And intercultural mediation is really, in my mind, after all the research I've done, it's a learned skill set where an impartial mediator uses a combination of culturally based language, behaviors, interventions, and information to improve the therapeutic rapport between culturally discordant individuals, in this case, patients and providers. So intercultural mediation has 2 terms, right? It's intercultural because we're talking about 2 different individuals with different cultural makeups, and the mediation component, which is managing that discourse, but also that interaction and that relationship. In healthcare, we have this concept of therapeutic rapport, which really, I think, touches on the issue of relationship and how that relationship affects care and affects outcomes. And I think that's why I say we're focusing in healthcare, because we're realizing that a rapport and an interaction is not just a one-time event. It really is about creating a safe space for the individuals that are communicating. So, what does the literature say? I'm talking about a, evidence-based discussion here. And the literature has, discussed the cultural role of interpreters back from the 90s, right? The IMIA standards includes it. In the 80s, we had Coffer and Coolidge talking about even separating that cultural role into 2 roles: the cultural broker informant, when interpreters were providing information to doctors and nurses about a cultural issue on behalf of the patient. And then you have the biomedical interpreter, which was a term they coined for the opposite, when interpreters would discuss this with the patient and the biomedical component or the healthcare practice that the patient might not be aware of. So it's very interesting that far back, there was already research talking about how interpreters do this work and how they even have to interact in a different way with the different parties they work with. So there have been many terms thrown out: cultural informant, interface, broker, intercultural and linguistic agents, separating those 2 issues that, we work with as a linguistic mediator, but also as a cultural mediator. Community agent, which is actually akin to that biomedical interpreter, which is looking at, how we represent our communities. Cultural clarifier, and I think I have a few more folks trying to enter, so let me just get them in, right? There we go. So they're joining now, and I want to welcome those that just arrived, and we're here discussing right now the roles of interpreters. And so the literature has looked at this issue, and really there's nothing new about that. But what I want to discuss a little bit later is just about what the controversy is about. So we know this is part of our work, and I want to ask, why are medical interpreters providing this service? And I'm talking about the cultural service. Well, one of our objectives is to improve the therapeutic rapport, right? So that's a standard, a very specific IMIA standard, which unfortunately some interpreters might not even be aware of. And how do you improve a relationship that's intercultural without intercultural mediation? There are also, the interpreters are also the professionals in the room who know the most about both cultures. And when I say both cultures, I'm just talking about, in general, different cultural makeups and how these participants might be affected by them. Each individual has their own intercultural makeup, and we cannot pretend to know what that makeup is. But we have ideas and we have some knowledge of frameworks, and we can read behavior not only from a linguistic component, but from a cultural perspective. So even though we're not anthropologists, we certainly are the individuals in the room typically who would be able to identify these issues. So we also are mediating language, right? There's no controversy about that, but you can't really mediate language without the culture. Culture is embedded in language. And oftentimes, in order to interpret an idea, that idea can be culturally based. And that idea or that concept might not even exist in another culture. So I'm not telling you anything you don't know, but I'm just saying these are some of the reasons why we engage in these cultural roles. And then there are cultural issues which arise, which impact the communication and the health of the patient, and also the cultural competency of the organization. And that's an argument I'll make, that our ability to engage in our cultural role has an effect in the cultural competency of the interaction, therefore the service that's being provided in that context. So what do the standards of practice have to say? I mentioned already, the research, is definitely, has told us that, has observed, has analyzed our cultural work. And the standards, it's very interesting. Every standard mentions the responsibility of the interpreter to address cultural nuances as part of their scope of work, every single one. And when I talk about every standard, which standards am I talking about? Well, quite a few. And as you can see here, this is a long list of standards. And I do want to mention that some of them are standards specific to medical or healthcare interpreting, whereas a few of them are community interpreting standards. And then there's a general interpreting standard. All these standards should be well known by interpreters. We should be taught based on these standards. These are sort of like the roadmap of our practice. And if we're a practice profession, these standards or benchmarks are quite important. I sometimes wonder if we're being taught enough based on the standards. Okay, now I'm going to throw a wrench here, and that's the elephant in the room. So what about Canada? A lot of people say, well, in Canada, we can't perform the cultural role. And here's one statement in the Canadian Community Interpreting Standard under responsibilities for interpreters and employers. And it states, the interpreter must be able to understand and convey cultural nuances without assuming the role of advocate or cultural broker. Now, this particular statement can be quite confusing to interpreters. It's actually a little bit ambiguous and contradictory, and I'll explain why I believe that. Well, the first thing that I want to mention is it's not for medical interpreters specifically. This is a standard for community interpreters. So it covers legal interpreters, conflict zone interpreters, police interpreters, right? Interpreters that work in different contexts. So the standards have to be very basic in the sense that whatever is stated has to work for everyone. And certain contexts may or may not allow for as much collaboration and the role of ensuring understanding, for example, does not work in certain contexts. In healthcare, that is part of our role. It's actually one of the standards of practice to ensure understanding. So how do you, explain this? Well, Annex 1 of the same standards speaks about the fact that in the past in Canada, interpreters were called cultural interpreters. And it states that 180 hours of training does not provide sufficient time to teach the cultural role. So it almost explains that it's trying to limit that role because it can't train to it, which is interesting. And the other question I have for you is, how do you convey cultural nuance without assuming a cultural role? And that's the contradictory portion, because conveying cultural nuance is a task of, it's a cultural task. Now, again, definitions, what's a cultural broker? Perhaps they have a different definition, but that can become a little confusing. And also assuming the role of advocate. Well, advocacy and cultural brokering have been seen as separate roles, although I'd argue that you can be a cultural advocate, you can be a communication advocate, you can be a patient advocate, and those are all different things. My study, which I'll talk about a little bit later, did find that Canadians do practice the cultural role regardless of this statement. And again, because the first part of it talks about being able to understand and convey. Convey means inform and, ensure that that nuance, that cultural context is conveyed to the other party. So there really hasn't been any research study where medical interpreters were observed not to engage in a cultural role at any point. So again, this can be a little bit confusing for many, and that's why we hear a lot of these statements, oh, in Canada we can't do the cultural role. But I would argue that based on their own standard, you can, and that's not what the standard says. So it's confusing, and this is why, it can be a problem. Interpreters can be confused. Who do we follow? Trainers are saying one thing, standards may say another. The practice demands are even greater sometimes. So it isn't until you're on the floor interpreting that you really see the demands and the expectations of the participants you work for. And that's when you have to make a practitioner's decision on how to best do your work and do your craft. So I had to be gender neutral here and offer another image. But, do you ever feel like providers or trainers or even employers don't quite understand the demand of the practice? Don't you wish sometimes that you could just put them in the room with you, with the patient and the providers, so that they could understand the dynamics that we go through? We're not just there for the linguistic aspect, and I think that's the biggest misunderstanding of our profession. And when we are placed in that very limited role, actually a disservice can happen, because you can basically convert information back and forth, but you will be denying the standard of ensuring understanding. You'll be denying the standard of improving the therapeutic rapport. You'll be denying the standard of providing culturally competent care. And these are all standards for our profession. So we have to be careful when certain guidelines are given that actually may contradict some of the standards that have been blessed by the entire profession. So with all this confusion, what are some of the problems in the profession right now? I mean, I wish I could open the mic and we'd stay the rest of the time talking about that. But I'll just put a few out here. In my mind, the limited scope of service, or at least the confusing scope of service, can be one of our problems. We might have different expectations from different parties. Forced company trainings and company testing. And what I mean by that is that as contractors, we really don't need to be tested and trained. You assume that you're hiring a professional and they know their work. Yet we are, I see a lot of interpreters being forced to go through a particular company training and testing, maybe because they're not certified, but now that shouldn't be an issue. Low professional status. Low remuneration and benefits, in some cases the misclassification of many as contractors when they should be employees. If you're being trained, tested, supervised, and monitored, then in many states, at least in the US, you really are not a contractor. But many lobbyists are trying to change that. And I'm not for one or the other. I think many interpreters want to be contractors, and that's fantastic. But if you're going to be a contractor, treat me like a contractor. You can't have it both ways. And then there's the lack of understanding of the services provided. And that's a big one. I even see some interpreters walking out saying, we just interpret, we're the voice, and putting out some information that I wonder, where did you get trained? So there's a lack of understanding even within the field, but mostly outside the field. And that's one of the biggest complaints. So I'm going to run through these myths and facts, okay? And regarding intercultural mediation. First of all, a lot of people think when they hear the term mediation that it is a subset of conflict management or conflict mediation. And it has nothing to do with that. You can be a diplomat and be an intercultural mediator. It has nothing to do with conflict management. You can be a teacher. There are many professions that also have to deal with intercultural mediation. Another one I hear a lot is, we're not anthropologists. We didn't study intercultural issues, so we're not necessarily equipped to explain cultural paradigms. Another one I hear a lot is, that it's only performed separately in mediation consultations. And there's this view that intercultural mediation is a separate service, which it can be, but there is nothing to say it can't be part of an interpreted encounter, for example. Another one is that interpreters should not engage in intercultural mediation unless there is a breakdown in communication. Resolving conflict is the primary goal of intercultural mediation? No. Again, that comes from that conflict mediation mindset. Not at all. Improving rapport has nothing to do with resolving conflict. Another one is that interpreters cannot be impartial and engage in intercultural mediation. Now, there's some controversy to, how impartial we can truly be, and we need to be real and understand that we have our own intrapersonal issues, but in effect, most mediation practices do argue for an intent of impartiality, because how can you be a mediator of two individuals without really stepping back a little and not taking sides? If you're taking sides, now you're a representative, you're not a mediator. Interpreters should focus on the conduit role and only address cultural issues by asking participants to explain themselves. I've seen many trainers state this. And while it is true that we should always value the opinions of our participants and really give them the opportunity to have their own advocacy of their ideas and share them, sometimes they do request that we explain certain issues, or sometimes they don't have the terminology or the understanding of what it is that needs to be explained because they don't know that the other may have a completely different view. To them, that is their worldview. And that happens a lot because when they go, what do you mean, explain this? This is how it is. And so sometimes interpreters do have to provide explanations. And that's where I think some of these become myths, because it's not only by asking others, sometimes we do have to step in. So therefore, some of the facts are that intercultural mediation is a high-level soft skill. It really requires high communication skills, high interpersonal skills, high intrapersonal skills, and so forth. We're mediating language and culture. Intercultural mediation can be performed before, during, or after a communicative event. So it can be an interaction in itself, or it can be a component, an interjection, or a moment within an interpreted encounter. Language concordant patients may also require intercultural mediation services. That's a fact. That doesn't mean that because they may require it that we can't actually provide the participants with that benefit because we're there. The training focuses primarily on linguistic skills. Interpreter medical interpretive training in particular tends to be very short and intense, and therefore there's very little time to address cultural issues. Sometimes it's addressed in just a few hours of the 40 hours of training. We could argue, obviously, that 40 hours or even 180 hours isn't enough, but a little more attention could be given to cultural issues. And then the impartiality issues. Yes, we can be impartial in the sense that when we are mediating, we are attempting to help both parties, not just one party. Now, why is this important? Why is intercultural mediation important? Why am I even putting such an emphasis on it? Well, again, I have to bring us back to the fact that intercultural interactions are going to increase. Some of them have a larger cultural gap than others. So if you're a Spanish English interpreter, maybe the gap isn't as great as when you're an interpreter of Urdu or Arabic or Mandarin. So just be aware that your experience as an interpreter may not reflect the experience of all interpreters. The wider the gap, the wider the practice is going to be. So our experiences aren't all the same with respect to intercultural mediation. And it is much more needed in certain linguistic pairs where the cultural gap is greater. East-West, religious, and other differences. So can we actually provide competent, culturally competent care if we don't act as intercultural mediators? I mean, that's a question I bring to you. And I have a quote here from one of my study participants that really, I think, sums it up. And she said, "The cultural services we provide are as important as the linguistic services. While we spend more time interpreting, there are instances where we need to intervene or educate the relevant parties on cultural issues in order to ensure the provision of quality care and culturally competent services." So sometimes I think the frequency of that practice gets confused with importance. And we have to really understand that these are two very different things. Just because we're not discussing cultural issues at all times, it does not mean that that is not important. So it needs to have its place, and we need to think about it as an important component of our practice, but it doesn't mean necessarily that we are discussing it with our clients at all times. And please feel free to, write your comments to what I'm saying in the chat box. I think it'll be nice to read later, and for our participants, feel free to have a side discussion as I'm speaking. So I have 3 slides about my study. I don't want to take too much time talking about it, but I did an international doctoral study on intercultural mediation. And what I did was ask practicing interpreters, what I call practitioners, what situations they encountered these issues and what did they do, how often or the frequency of engaging in this practice, the strategies that were used, advantages, disadvantages, challenges. All this was explored, and I asked them if they were receiving enough training in this, how interpreting culture or the cultural practice affected or impacted the delivery of healthcare, not only from a culturally competent care perspective, but also from a medical perspective. Did this affect the outcome? Did this affect patient compliance? Did this affect patient satisfaction? And specifically, did this affect the patient's healthcare? Now, what are the stress factors? That was another question that came up, because in my interviews, a lot of people discuss the stress of addressing cultural issues. Now, my study was done at Osaka University in Japan, but it was international. I interviewed interpreters in 5 different countries, and I did a survey that reached another number of countries. So in total, we had practitioners from 26 countries answer the survey. And I'm just giving you here a little tidbit about some of the questions. And obviously, timing everyone said it depended on every specific encounter, which really talks to the fact that every encounter is unique, and that interpreters are really thinking not in terms of rules of engagement, but of answering to the demands of the work. You know, if you haven't read about the control demand schema, I suggest you do, because it's a really great way to look at our practice. And this comes from this study really had two premises. One, that we're practitioners that actually have to make decisions. We're not just robots verbalizing or signing messages. And two, that the practicing interpreter is the ultimate expert of his practice or her practice. So those were two assumptions I made, and I really wanted this study to reflect the voice of the practitioner. A lot of studies are ethnographic, and you know, as researchers, we can observe interpreters and what they do, but I wanted to get into their minds and ask them, why do you do this? Why do you not do that? And they gave great explanations. So here, the specialties in order of frequency that require more intercultural mediation. So mental health was number one, followed by maternity, labor and delivery, family medicine, emergency medicine, gynecology, and pediatrics. So these are just some of the results that came out of the study. And I'm reading everything because I want to have an audio version of this, and I want to make sure people that can't see will be able to follow through with it. So I just wanted to give you these quick slides about the study, but there's really a lot more to it. This is a quick partial list of the intercultural tasks that interpreters described. Some of them were in the pre or post session tasks. Others discussed, you know, assisting the speaker to develop a cultural explanation. So that's when we really ask the participants to go ahead and formulate the issue, assessing the dynamics, urgency, and centrality of the issue to decide whether or not to intervene and when, assessing the best time and method to raise it, paying attention to the verbal and nonverbal cues and cultural needs, interjecting and making these issues explicit, prompting the provider and patient to search for clarity, explaining culture to the provider or patient separately. This is what happens usually in the pre or post session tasks, and reformulating the message so that it's culturally appropriate. That's one of the strategies that individuals discussed. Now you can see from this chart here that, you know, some of these are seen and some of these are not seen by participants. And why did I want to, you know, mention this? Well, because a lot of the work we do is really invisible. It truly is. Participants only see us, you know, verbalizing what they think typically is just repeating what the other said. And a lot that is going on while we are interpreting. We're simultaneously assessing situations and making decisions at the same time we're interpreting. So this is really showing us that, you know, we're doing a lot more than the cognitive functions that we're using are more than linguistic. And we are making decisions about how to address these issues. Even though it might seem simple, even when we reformulate it, we have to think through how to reconstruct the message in a way that will be understood by someone from another cultural background. So I just had those 3 slides because I did write a book based on the doctoral research. So if you're interested in getting the information, it's available everywhere. And, you know, I have to say that some people want to dive into it a little bit more. So I just gave you 3 slides so you can have an idea of some of the topics we talk about. But reading, it's available on eBay cheaply and all these other locations as an ebook, hard book, soft book, everything. So let's get to the really interesting portion of the discussion here. So why do I say it's controversial? Well, let's see if you all agree with me, but there's some issues that are more controversial with interpreting, and this is one of them. Why is it controversial? Because it speaks to a very important dynamic in our profession, and it speaks to the scope of work of the interpreter. So we've really started our profession from the invisibility paradigm, right? The less they see us, the better. If the interpreting goes seamlessly, that means, we almost forget the interpreter's there. That interpreter was amazing. And I would argue that you have many interpreters really thinking that not interjecting at all means that you had a seamless flow of communication. And I would argue that you could have a discussion between two individuals where everything was interpreted accurately from a linguistic perspective, and then both of them walk out of the room and the patient asks and says, I didn't understand a thing. What exactly happened there? Can you explain it to me? Now, that's what I call a breakdown in communication. It wasn't a breakdown in interpreting. The interpreting was perfect, but the interpreter didn't address the ensuring understanding, the communication aspect of it, the rapport aspect. So we have a lot of interpreters walking around thinking that being the message conduit is all they should do, and that they should only address other roles, when there's a breakdown in communication. So the lower scope of work, is that typical I just interpret, or you have the provider expectation that tells you just interpret, just repeat everything word by word. We hear that a lot. And we hear it so much that we might internalize it and start saying, well, I'm just the interpreter. I'm the voice. I'm not part of the conversation. And while these are all true, research has shown that we are participants and that we do affect the interaction, and we do affect where the communication goes based on our interjections. I never call them interruptions. They are interjections, and they are part of our work, or interventions, you may wish to call it that. So in the invisible scope of work, interpreters are seen as language technicians, language converters, and we're addressing the linguistic disparity very well. And it's really a linguistic paradigm. And the last block there on the left, it's providing linguistically competent services. And I would argue that we're actually focusing a lot on that. That is important. Without the linguistically competent, we really can't add anything onto it. That is the foundation of our work. But I would argue that, we really need to look at a larger scope of work that addresses the cultural issues in a greater way. We can be intercultural mediators and still remain within our scope of work. We can provide information when requested and when needed in a responsible, professional way. We can be cultural competency advocates as innate in our work. That's what we're there for. And we have a multiplicity of roles, and I even prefer to say tasks or responsibilities, because this whole role paradigm has really hurt us, I think. The provider expectation needs to change to help me communicate and understand. How we present ourselves needs to change. Instead of saying, oh, hi, I'm your interpreter, I'm here to help you communicate with the patient and make sure that you understand each other. That's a very different paradigm of service. And that's a very different way of looking at our profession. Are we communication professionals or are we linguistic professionals? And there's a difference. The institutional support means that as we act more as intercultural mediators, we will be seen as communication professionals that are essential to cultural competency. But we need to believe that and act upon that. We are already doing it, but we're doing it in a very soft way. And many interpreters in the study told me, well, it depends on the provider. My institution doesn't allow it. Sometimes I see the need, but I really can't. My employer, many agencies don't want to hear from their clients that the interpreter overstepped, and many providers don't want any insinuation that, culture is an issue. But there are very diplomatic ways in which we can engage and have teamwork with providers. And I think more training on that could really help us not have that pushback. So ultimately, you know, the paradigm has to shift from a linguistically competent services only to a culturally and linguistically competent service. And I say medically there, not because we're providing medical services, but our services also have to be healthcare oriented. Those of us that work or have worked as staff interpreters or really are specialized in the healthcare interpreting field, really, it was amazing. The study showed that many of the interventions were related to healthcare concerns for patient safety, for patient satisfaction, for provider cultural competency, and for patient compliance. If you don't understand the reasoning about a treatment, you won't comply with it. And if there's any cultural difference between treatments and between how things are perceived, that really affects the outcome. So if we're going to provide culturally competent services, we have to be able to provide our services in a way that really involves the context of what we do, and so that providers can see us as partners and you know, team players in this, and not just a mouthpiece. So to me, the controversy is really about the scope. And I see a lot of trainers, employers really trying to limit that scope, mostly for what I would consider liability concerns, but not liability because we can make errors, because we already have liability of linguistic issues. It's the liability of having complaints, liability of having issues arise that providers are not comfortable with. And so it takes more time. So I think a lot of times the concerns may be related more to, let's keep it simple. You know, you may or may not be able to address this. This may bring conflicts, and it's easier if we just handle the language. And I have to say as well, our specialization evolved from conference interpreting, which was the considered interpreting. It's really a specialization, and it's much more linguistically focused. In dialogic interpreting, especially in healthcare, we have to really work with the patient and provider to agree and to work through a plan. Now, if they disagree, that's fine. We're not there to make them agree, but we are there to help them just have an open discussion of understanding. Okay, so I'm going to break this up by putting this slide here, and it's the other elephant in the room, which is, you know, what about us and machines, right? And the reason I put this here is because I want you to pay attention to this slide. And this slide is talking about what could be the benefits of a broader scope of service. And I say broader, you know, in parentheses, because it really is within our limit, but broader in the perception of others. First of all, it would give us higher visibility and status, a higher level of collaborative rapport with the provider. When you start talking about culture and communication and understanding, it takes on a different component than just discussing, you know, I'm gonna interpret everything the person says. That really doesn't involve any teamwork. Higher pay, possibly, question mark there. But I would argue that if we market ourselves with higher skill set, we definitely have at least an argument for higher compensation, or not for the free fall that's happening right now. We're not as easily replaceable by outsourced interpreters who don't understand the US healthcare system. And I value all the interpreters that are working abroad, that are working with the US healthcare market. That's perfectly fine. And I'm glad that we have a market that can fit everyone, but it is incredibly important that those interpreters know the US healthcare system and understand some of these cultural differences, and are not only coming from the perspective of the patient. They need to have both. And outsourcing is something that's happening quite rapidly in our field, especially now that remote interpreting is taking over in-person interpreting. And it is a threat to US and European interpreters. And I apologize for those that are abroad, but focus on learning the cultural components, and then you'll be fine. And we're also not as easily replaceable by machines. If we continue to say we're mouthpieces and we're conduits, which is a term I absolutely abhor, we will be replaced. And it's not, unfortunately, people say, oh, you won't be replaced by technology. You know, we are already being replaced in many situations. There are many ambulance services that are using machine translation already. So it's getting very difficult to say that with a straight face. So if you don't want to be replaced by a machine, don't be a converter. So think about it. If you portray yourself as an intercultural mediator, do you think machines can replace that component of our work? I don't think so. But I would argue right now that that component of our work is almost invisible. Nobody talks about it, we don't address it very much. And certainly employers and healthcare providers are not marketing the cultural services we provide. They're only marketing the languages we speak. And last of all, another benefit is that we wouldn't be easily replaceable by family members or friends. Now, when you say I'm the interpreter, the provider may say, oh, that's okay, we don't need you. We already have mom here interpreting, or, you know, brother or whoever. When we say I'm here to help you communicate and address any cultural issues, or if we say I'm your linguistic and cultural mediator, the provider is going to have to think twice about saying, oh, hold on, you know, that family member is going to be the intercultural mediator. I don't think so. So we really, I would argue that we could start a process of rebranding our profession, not to change who we are, but to acknowledge what we already have, acknowledge some of the areas of expertise that we have, whether tacit or not, it doesn't matter. The fact that we are bicultural, multicultural, bilingual, and we do have years of knowledge that need to be acknowledged, recognized, and frankly paid for. So think about it. How do we want to be portrayed in the future? Because the term interpreter is akin to person who interprets. That's the term. Unfortunately, we have to say professional interpreter now to differentiate ourselves from a non-professional. Even the term, you know, what's the term that's used a lot? The ad hoc interpreters. That's a horrible term because it's using our term interpreter to describe non-professionals. They should be called linguistic assistants, individuals who are helping linguistically, but they're not interpreters. So let's stop calling them ad hoc interpreters. Let's stop calling interpreters people that aren't interpreting. We cannot prevent that in the public world, because people, if they hear some semblance of interpreting, they think that's interpreting, but usually the person's, you know, relaying half the information, usually badly, but you know, it's pretty sounds like interpreting. And that's a big weakness in our profession, is that it's very difficult for outsiders to evaluate the quality of our work. Very difficult. But we have to really own and consider how we are marketing our services, and are we, you know, allowing and being shortchanged by not being valued and respected for the cultural knowledge and skills that we bring. And you know, I'm closing in that slide with two pictures so you can really think of its importance. If you want to differentiate yourself from the crowd, it's becoming ever more important. So do you want to be just one more interpreter that interprets and has an interpreter certificate and maybe an interpreter certification? Or do you want to add value to your services? So when you know, what I'm proposing here is that we really look at our work and how we market ourselves and what we believe is the work that we're doing. And again, I'm not saying we're going to be discussing culture at all moments with our clients, but we are going to put it as, you know, something that we do. Is it part of your introduction? And if it's not, I argue you should put it. You should really start thinking of how you market yourself and ensure that if your resume doesn't say culture in it, you are shortchanging yourself. So think about that. And again, this is supposed to be a thought-provoking session. So what are the naysayers going to say? Ha ha, never, impossible, no, right? And I'm realizing we're reaching our hour, so I'm definitely a little bit behind. But, you know, many are going to say we're not ready for this. There are dangers involved. Already mentioned, that's what they said when we wanted certification. We already have liability with linguistic issues, so it doesn't really change that. We need standards of practice and training standards. Well, as we get more and more intercultural mediators, maybe that might come in the future, but it's not necessary because it is part of the interpreting work, and it is already embedded in our standards. It won't change our status or pay. Well, that's what they said when we started requesting pay. I remember many employers and many hospitals saying, well, interpreters will never get paid because we can get them for free. Well, not true. We're going against the standards? Not really. Study your standards and you'll see the amount of work on cultural issues. We need to stay within our scope of service. We are within our scope of service. Please read the scope of services in the standards and understand that culture is in it. If you're not practicing it, you're not practicing within the scope of service. And that providers won't accept it. Again, these were the same arguments we always heard. They will accept it if we put it in a way that is beneficial to them. So there's a website. I actually did create a course on intercultural mediation. And the course, you know, I want to quickly just show you very quickly the curriculum of the course. It's a self-paced course. And the whole, and I'm just going to browse through it here. This is the curriculum, and it addresses several issues of the study, you know, the strategies, some of the cultural gems that happen. And it's the attempt here is not to sell you a course. As I mentioned before, I think we already do this work and we're already equipped for it. But what I see is that individuals might not see that this is something that they should market. Okay, slideshow from current slide. There we go. Let's come back here. Interpreters may feel more comfortable if they have a certificate in their hand. And the reality is that we don't have anything usually to quantify or verify our cultural competency and our cultural knowledge. So having a certificate in intercultural mediation may be something that's helpful to you. It may be something that you might feel will help you in requesting more pay or in engaging in more cultural activities within the healthcare organization you work for. But again, you can just read the book and get all that information. Or again, you can just, you know, continue practicing, but with a higher awareness of the cultural perspective. So I want to turn naysayers to yaysayers. And we need to create more champions for innovative ideas in our field. And I frankly think that really working to readdress our scope of work and readdress who we are as a profession, especially as a specialization, will be really important in our field. Otherwise, we're going to get eaten up as voice boxes, and it's not even the outsourcing that's going to be our biggest issue. It's the actual work that we are seeing done in neurolinguistics and some of these translation technologies, translation voice technologies are becoming quite advanced and quite impressive. And do not be fazed. Providers will not necessarily need a perfect system. They may be very willing to work with an imperfect system. So I wanted to open up the discussion. I'm gonna see if, please, you know, unmute yourselves. I wanna make sure that we all get a chance to talk about, you know, have you been taught a narrower or broader scope? Do you have any comments that you wish to make? I don't see any comments in the Zoom. Do you think a course certificate will benefit you or the profession? Maybe a certification in intercultural mediation in the future. But I would love to hear from participants on some of these ideas. And I'm going to close this so that we can focus on the discussion here. Let's see, stop the share. Go ahead. Let's see if we can open it up.
I'd like to say something. Can you hear me?
Yes, Barb.
Yeah, for me, you're preaching to the choir. I feel that the people who are most adamant saying this is not within our role, we're not allowed to do this. I think the problem is that for medical interpreters, the role of medical interpreters was based on, first of all, court interpreting, which is a whole different adversarial type of system. Whereas in a medical setting, at least in my opinion, everyone's goal should be to do the best for that patient. However, you know, the provider, every provider involved and the patient themselves, it's not an adversarial system. And we're there to, and that involves being a broker and at times an advocate. So anyway, that's my 2 cents. You're preaching to the choir with me. And I also agree with what you're saying about contractors versus staff. I'm a person who was full-time staff at a hospital and got downsized out along with we only had 2 interpreters in the hospital and we both lost our jobs. And it left them with a very inadequate system to take care of all of the, in that location, we were both doing Spanish. We had lots of clients coming into the hospital, lots of patients who spoke Spanish, and really poor system for taking care of them once we were both gone. It was just it was a money cutting measure. So, So anyway, I'm a big advocate for having staff interpreters because you can develop rapport with staff. And I mean, and really it's about relationships. You can almost, you know, you have a shorthand with people if they know you. You know, you can kind of give a person a look and they know what you're getting at if they know you, and vice versa. So I think it's important to have that possibility as well valued more in our US system. Okay, I'm done.
Thank you, Bobby. That's great to hear. Appreciate it. And that is an issue that's happening. A lot of interpreters have been let go in lieu of telemedicine or remote interpreting.
Hey, Isabel.
Oh,
Robert.
Hi, Robert Lee. How are you doing?
Hi. Very good. Again, preaching to the choir as well. I'm now in England, as you might know, and the NHS here is one of the places I always thought would have staff interpreters, and I've been advocating for them to, because it's a perfect system for that. And it's still this fighting of the, oh, we can just bring in people as contractors and all that. But to get to your point, I think the idea of having a certification is great, or having, you know, some other kind of qualification alongside our interpreting certification that says this is augmenting, but also a part of what we do. And as you might know, the work that I've done with Peter Llewellyn Jones on role space, part of the reason we did that was because of the problematic concept of role. We wanted to come up with a way to conceptualize what effective interpreting is. And if we talk about enacting roles and not having roles, that gets us a lot further. And part of what we talk about is the ability to align with participants, all the participants, the patients, family members. And role space really came out of a way to conceptualize away from the conduit model, but also capture appropriately what we do. Unfortunately, codes are way behind. And I think the codes need to be reflective of practice. And that's one of the things we need to advocate for is to really have codes be reflective of what we know is successful, accurate practice, and not just because the code says it, because the code was written 15 years ago. So I mean, I'm a big advocate for role enactment, and that's what we do. And I think that's what you're talking about.
Yeah, but even the codes do mention culture. So I don't know where these ideas come from. I mean, I wonder if the standards and the codes are really being studied carefully, because They are not against
No.
all of this, and I would argue it's part of it. I just created a course with a certificate just to quantify the knowledge. I'm not sure about certification because this is not a separate profession, or this is not
No,
a
I meant as a certificate.
Right.
You know?
We do this work. Every researcher that looks at it has seen that this work is being done, but we don't talk about it, and it's not really understood. Many healthcare organizations just perceive us as language professionals, and while that's not untrue, we're more than that. So I'm talking about just, let's value all our skills. Let's help others understand all the work we do, and not just the language part, because the cultural component is important. And this idea that we can't discuss culture, I find a bit patronizing, because I see interpreters incredibly responsible. The study showed that most of them are very responsible with what they say, when they say it, and they think it through, and they're not assuming. And of course, some of it has to do with training, and that's a whole other topic, but that doesn't preclude the fact that interpreters will be discussing issues, because they are doing it. If they're not doing it right, then we really need to look at the training and improve the training. And hopefully employers and healthcare organizations can really also push for better training in this area, because 40 hours frankly doesn't cut it, even for the language component.
And just to add, I think one of the things that you've been saying too, I think that's important, is that culture is all around us. And I think what's happened is culture has always been, oh, it's the minority language speaker has a culture, and you have to deal with that. It's like, actually, no, cultures are on all parts of the equation. And I think if the more we can highlight that, and practitioners can realize that, yes, just like you think you don't have a culture, you think you don't have a dialect, you think you don't have an accent, actually everyone has that. And we're there to work with the majority of the multitude of cultures in the room. So great stuff. And it's great to see you, by the way. Yeah,
it's great to see you. Go ahead, Kathy. It's so nice to see you.
Yes, hi. I'm just so grateful to you. You're preaching, I think, mostly to the converted. So thank you for putting this course together, and I hope it's the beginning of better changes. And then I wanted to speak with the participants, since I did take the course already. I wanted to encourage everybody to take that step in the process of helping to push the profession forward. I felt like the course was very easy to navigate. I know a lot of people are very maybe they're uncomfortable with technology, but it was easy to navigate. And I felt like for somebody, like, I sense that most of us are thinking it's time. This is the way we should have been going. And not only does it teach us on our own to be more reflective of our biases and be better cultural mediators, but also in the course you also understand how to speak to other people, because a lot of people are data driven, and they always want to know, well, you're just saying this is what you feel, but because Dr. Sousa did her study as well, there's a lot of information that helps you, not only teaches you to be a better cultural mediator, but also to speak to other people about it. So I would recommend it. And another thing that I really liked about the course, personally for me, for some of us that want to dig deeper, she gave a lot of resources of other studies and so you can really delve, it's really a launching point. And to me, it was a good guide to study further, and to my personal study to take that further using those resources that she gave. So I wanted to thank you. I know I told you a while back, when are you putting this together? I've been waiting for it. I said, as soon as you put it out, I want to take it out. I want to take it. And just for anybody wondering who I am, disclaimer, I just speak personally. I mean, I am a leader in a couple of, have been a leader in a couple of organizations, but I only speak here for myself. I'm not reflecting anything any organizations are standing behind or anything. So, but I'm a CMI, and I've been in the profession for 10 years, and I love this work, and I hope that out of this, not only do more people take the course, but I think that, and I hope that there's a good handful of us that are willing to get our hands in there and move it forward and push it forward. It can be done as long as there's the energy, and as long as, you know, we don't give up and we're well informed. It can be done, and it should be done for all the reasons that Dr. Seuss had talked about. So anyway, thank you, and it was nice meeting you all. I hope you have a good year. I hope things are better for all of us.
Yes, thank you so much, Kathy, for sharing about the course. I appreciate it. Anybody else want to talk about just this idea of a more limited scope of service, a broader scope of service, or even just following the actual scope of service in our standards, which includes all these issues that I think are being neglected, like ensuring understanding, improving therapeutic rapport. These are standard-based items and research-based.
Yeah, Isabel, I'd like to say something. I'm
Yes,
sorry. I apologize. I'm at work, so I have to have the mask. This is the passion, the road, the journey that I have been taking for a while. The need was there. I'm an Arabic interpreter, certified for 10 years now, a trainer. And I really would like our profession to move forward. I call myself the interculturalist interpreter. And I think it's not just an interpreter. Now, I am also the mediator. I mean, this is the same thing, but this is what I'm trying to do. I am having difficulties within our institution and basically nationally with this idea. And I feel like we need to push this forward as a profession. That, yes, it took a lot. I took my master's in intercultural studies. I did, you know, you do have a lot of training to do. And the idea of the different cultural gap between different languages. I think if you're in one language, you are biased toward that language. And well, why can't we standardize? Why can't the idea of standardization of the interpreter? I think this is something that I'm facing a lot, because I was really asked to, I cannot do anything beyond, I have to stand. But I said, but this is part, and I'm a trainer, and this is part of what we do. But everyone, the physicians love it. And the patient's experience is better. The safety outcome is better. And, you know, but this is like, I feel like we're in a, I don't want to call it a paradigm, but in a valley trying to get up with this idea, how to push this forward. It is so needed. It is so valued. Yes.
Yeah, it seems you're sharing this dichotomy that, you know, we're trying to perform our role and we're being told, you know, to limit it. I would suggest, you know, you show the book or just print the standards and show the standards and actually show this is part of my work. Let me do my job. And I think, you know, as professionals, as practitioners, we can't be just seen as technicians. We are making decisions, but they're very carefully thought out. It is not as if interpreters are overstepping boundaries and, you know, going irresponsibly about their job. I mean, especially if they're certified. Now, I see some people are leaving, and I apologize for the,
thank you.
you know, for us going overtime, but I wanted to make sure I gave you an offer for everyone that has joined the webinar. I have a special coupon. The course is an online course, self-paced, and its cost is $4.99. And for those that attended this webinar, I'm actually offering a coupon that will take off $250. So it will basically cut in half the course if you enroll in the course before Friday at the end of the day. So just email me at isabel@interculturalmediation.org if you're interested in getting this coupon, and I'll send you the code, and then you can join for half the price. I mean, I do think that having a certificate in a topic such as intercultural mediation can be helpful. But if you're not interested, as I said, you know, you can print the standards of practice, highlight the areas that have to do with culture, and that in itself should be a way for you to document. Learn about the class standards. I'm actually creating a course on the class standards so that interpreters can be very knowledgeable about class and be able to speak on it. I really believe that interpreters can become, you know, very important intercultural agents within healthcare organizations to become more culturally competent. I've followed the cultural competency wave from the very beginning, and it's shifting very slowly. It's shifting slowly because there's nobody to fan the fire of cultural competency. And who better than interpreters who are literally going everywhere providers will learn things much better if at the moment, not at a box lunch, you know, days later, when they have the patient in front of them and they're faced with a cultural issue. That's when they realize, and I've seen so many interpreters increase the cultural competency of their organizations by just giving tidbits of information to those that they work with. And many of them are very valued for that. So I want to thank you all for participating. I hope we can have another debate. Maybe in the next round, I'll just do just a debate about the topic. I think it would be interesting to hear the different viewpoints and also to understand some of the problems that employers and healthcare organizations have, you know, in hiring interpreters that are equipped, that are really, you know, offering the services that they're looking for. And then the challenges of remote interpreting and how to address these issues in remote interpreting, which can be quite difficult. So thank you all very much for joining. And as I said, my email is isabel@interculturalmediation.org. You can join me there. If you're interested in the course, just go to interculturalmediation.org and you'll see it. If you want to participate and get blogs, you would have to sign up either in the mediation website or the Institute of Interculturalism.org website. And you can get two different blogs. One's just on intercultural mediation. The other one is more on health equity, class, and everything that has to do with cultural competency in healthcare. So thanks again, and have a wonderful rest of January. And thanks to those that I know, and I see Jeanette Torres as well, and so many people here that I know. And sorry if I'm not naming all of you, but it's really, really wonderful to see you. I hope to do more of these soon. So with no further ado, I guess we're going to end the workshop. And thanks again. Oh, look, we have visitors. Okay, bye-bye.